Welcome to this video on lichen sclerosis, or LS, in pregnancy and postpartum. We'll be reviewing comprehensive care from preconception through lactation. LS is an inflammatory dermatosis affecting up to 3% of the population. Key features include white sclerotic plaques and possible complications like resorption of the labia minora. When treated, there is a low malignant change risk of less than 1%. LS is an autoimmune condition with a genetic link, showing a high prevalence of HLA-DQ7. Currently, there are no commercial blood or genetic screening tests. Only 12% report an affected first-degree female relative, so advise patients to watch for symptoms in female children. During pregnancy, symptoms often stabilize or improve. However, there can be a severe return of symptoms postpartum, with 60% reporting worsening, emphasizing the need for continued vigilance and management. The gold standard treatment is ultra-potent topical corticosteroids, such as clobetasol propionate or mometasone furoate. The application amount is about half a fingertip unit. Treatment involves a tapering schedule. Avoid calcineurin inhibitors and oral retinoids due to their teratogenic effects. Contrary to the myth that potent topical steroids cause birth defects, it is a fact that TCS is highly safe to continue throughout pregnancy for LS control. Evidence shows no association with congenital abnormalities or adverse fetal outcomes. Delivery mode is not dictated by LS. Vaginal delivery is the default for well-controlled LS, with no increased risk of obstetric tears. Cesarean section is reserved for severe intraulital scarring or major patient anxiety. Care should always be individualized. The postpartum flare is driven by three factors: a hormonal shift post-gestation, drop in compliance with treatment, and mental health challenges. Over 30% of this population face postpartum depression, double the international average, driven by pain and anxiety. Prolonged lactation can lead to vulvovaginal atrophy and genitourinary syndrome of lactation, or GSL, due to extended estrogen deprivation. The diagnostic trap is that GSL symptoms perfectly mimic an LS flare, making diagnosis challenging. When a patient presents with postpartum dyspareunia after 6 weeks, a differential diagnosis is crucial. Assess for structural issues, perform a swab for infective causes, check pH for hormonal changes, and look for white plaques and architectural changes to diagnose an LS flare. For LS flares, restart or increase the frequency of topical corticosteroids. Low-dose intravaginal or vulval estradiol is used for atrophy/GSL. Refer patients to pelvic floor physiotherapy for hypertonicity or muscle tenderness. Silver nitrate application can treat granulation tissue. A common fear is that estrogen in treatment will pass into breast milk. However, low-dose vaginal estradiol has undetectable systemic absorption. This treatment is highly safe and effective for VVA/GSL in breastfeeding mothers, so do not withhold it. In summary, pregnancy is protective for LS symptoms, and topical corticosteroids are safe to continue throughout. Vaginal birth is the default. Be aware of the postpartum crash and treat with TCS plus local estrogen for symptoms flaring due to GSL.